and then we'll have lots of time at the end for you to ask any questions. So maybe as we go through, if you have any questions, just pop them in the chat or feel free to save them to the end, and you're very welcome to turn your microphone on and ask them. And at that point, we'll turn the recording off so that hopefully you can all feel comfortable to ask your questions in a safe space without worrying that that is being recorded. We are running a little Mentimeter, but actually I'm just realising that we maybe haven't opened that Arenia yet, so we probably should open that in the background. Just suddenly remembered that as well. So while Arenia does that, just want to give a quick trigger warning that obviously we both work in anatomy, and in doing so, the material we cover can display images of what the reproductive anatomy actually looks like in real life. So just to say that some of the images might be a little sensitive. So we would encourage you to, if you feel uncomfortable, feel free to step away or avert your eyes. I think there's probably only one image, and I'll let you know when it is coming up. And I think from Aurelia's face, I'm thinking that the Menti's not opening up quickly. So if there's anything you want to know, maybe the quickest option is just pop it in the chat or ask us at the end if we don't cover it, and we'll get it working by the end for you to give us some feedback. So in the meantime, I will just get started with a little bit of background about why we think it's important to understand female reproductive health. This can be a topic that isn't always at the forefront of attention, whether that's in research, in the media, in general conversation. It can be something that people can maybe find that there's a bit of stigma around. People sometimes can be a bit embarrassed about talking about reproductive health and reproductive issues. And we'd really like to promote a greater understanding and a greater comfort in talking about this. We think that's really important because it obviously helps promote health and well-being. If an individual knows more about their body, knows more about their female reproductive system and organs, then it can help them manage and maintain their health and identify any issues. If you know what is typical, then it helps you to identify if anything might be an irregularity or something that might be of concern that you want to speak to a medical practitioner about. Knowledge is power, right? So the more knowledge you have, the more it helps you to be informed about your choices regarding sexual health, family planning, contraception, and medical care. It can help really break down the stigma and misconceptions, all those myths and taboos surrounding menstruation, menopause, reproductive health. I think it never fails to surprise Urania and I, because we've been working in this field for so long. We feel like a lot of what we're covering today is the bread and butter of these sorts of conversations. But actually, it's really important for us to remember that not everybody has access to the knowledge that we have because of our employment and our training. So helping to share that knowledge can help others break down the stigma and misconceptions and promote a healthier social perspective when it comes to reproductive health. We have to acknowledge that there is, of course, still a gender disparity and inequality often when it comes to healthcare, and not just gender, but other protected characteristics that can lead to inequalities. But today we're really focusing on the gender inequality and the importance of advocating and empowering women to be able to advocate for their own health and equal access to care. And if you have a good understanding of the anatomy and physiology, what organs you have, how they work, what the proper names are for them, then it can really help you understand your body and therefore communicate effectively with medical professionals, leading to accurate diagnosis, better treatment and better care, hopefully. So we thought we might start off with a few historical misconceptions and inaccuracies that people might find interesting. So historically, many anatomical studies were conducted in a very male-centric way. And that is probably the underlying basis for why we still see a bit of male-centric bias, a male-focused bias when it comes to medical healthcare, medical research, etc. Early anatomists like Galen, for example, believed that female anatomy was actually just an inverted version of male anatomy, whereby the ovaries were considered female testicles, for example, which shows a grave misunderstanding in the early understanding of the female reproductive system, in thinking that it is just sort of the same as the male, which we now know that it is, of course, not. In ancient times, the uterus used to be thought of as a mobile organ, an organ that could wander around the body, leading to the condition known as hysteria. Now, the term hysteria actually comes from the Greek word for uterus, hysteria. Irania can pronounce that much better than I can as a Greek native. But this really reflects a mistaken belief that many mental and physical ailments in women were due to a wandering uterus, hysteria. And actually, that's why, it's an anatomical misconception. The uterus or womb does not wander around the body. It is very much fixed in place, but it isn't fixed to any bony structure. So that might be what led to the misconception that it is, in fact, a wandering organ. But it also brings light to the term hysteria. Often we think of the word hysteria in relation to something that a female can be. And the connotations that come with that word should maybe be considered in light of this historical meaning of the wandering uterus. Another misconception was that early anatomists believed that males contributed all the essential material of life, while the female was simply the vessel for the development, i.e. the womb or the uterus was where the baby grew, but that individual didn't actually contribute any of the essential material for life, is the statement, which of course is not true. The role for eggs or oocytes in reproduction came much later. The understanding of the role came much later. But we now know that very much 50% of the material for life comes from the sperm and 50% comes from the egg. And the female then also contributes the womb on top of that. Continuing on with those misconceptions, another one is around menstruation. So menstruation has been historically surrounded by many myths and misconceptions. Early days, they thought that menstrual blood was actually toxic, leading to many cultural taboos and practices that might still continue in some cultures today around menstruation. Even in modern times, there's still a lack of understanding of the menstrual cycle in a lot of medical literature, with us not really fully understanding how and why things happen. The clitoris is another area that was historically neglected in anatomical research and indeed not even acknowledged in some medical textbooks. Only recently has there been a more comprehensive understanding of its anatomy and function. And lastly, the uterine tubes were not fully understood until much later in anatomical studies. Previously, there was some confusion around how the eggs travel from the ovaries to the uterus, and the function of these tubes was largely mysterious, but we now know that these uterine tubes are what connects up to the uterus, and it's the pathway for the oocytes or eggs to travel along. And we'll talk to you about that anatomy this evening. But before we get on to talking about the anatomy, I just wanted to take a few moments just to touch on some of the terminology that we're going to talk about today. So we can't talk about reproductive health without talking about the concept of gender and sex. Now, these are terms that are very topical at the moment, and I certainly don't want to get into anything political right now. But when it comes to talking about, sorry, I've got a little child peeing behind me. I'll be up in a little while, okay? Apologies for that. So when it comes to the terminology, gender is something that we think of more as a social construct, how you perceive yourself, whether you feel that you are a woman or whether you feel that you are a man. And that term was first coined in 1964, and it's thought to kind of be linked to behaviours and attributes that are based on the labels of masculinity and femininity. And so this is increasingly considered on a spectrum these days. Yes, at either end we have the binary man versus woman, but When we think about the inclusivity of this, sometimes people can feel that they are somewhere on the spectrum and don't align themselves completely with man or with women. Whereas sex is a biological construct, it's something that relates to our chromosomes, our genes, and it is established when the embryo was first formed. So sex is something that you would be assigned at birth. The baby, when they're born, would typically be assigned as male at birth, with the presence of an X and a Y chromosome, or female at birth with the presence of two X chromosomes typically. And it's believed on a scientific basis that it's the presence of those chromosomes that then determine which genes or DNA that you have present, and that in turn determines whether you are going to develop the typical male or the typical female reproductive system. Now, the UK government define this, as I said, as something that is assigned at birth. And for today, whenever we use the terms male and female, we will be referring to that anatomy, that biological term, rather than thinking about the concept of a man versus a woman. So if I say we are talking about the female reproductive system, that is the reproductive system that would typically form in an XX individual, which would be the typical structures we would expect to see in most individuals who associate with being a woman. But just to say that actually there can be some misalignment between whether someone is male or female and whether they think they associate and feel like a man or a woman. And just a very brief point, I'm not going to go into too much on this, but just to say that that gender identity, that biological sex and sexual identity can be independent from each other, but also independent from an individual's sexual orientation. So sex refers, as I've said, to the biological aspects and the structures like your genitals, your ovary, etc. And this is what we will tend to refer to in biomedical studies. As I mentioned already, we have this typical male, whereby that individual would typically have an X and a Y chromosome and male genitalia, as opposed to the female who would typically have two X's. We do have instances where someone can deviate from this, and this is known as differences in sexual development. It used to be termed as intersex, but we have moved away from that term now and we use differences in sexual development instead. And this is where a person's reproductive development might have deviated from the typical male or female characteristics with variation in their hormones, genitals, chromosomes, etc. Now, having differences in sexual development is nothing to do with being transgender. That is whereby somebody chooses actively to change their gender. Whereas differences in sexual development is typically something that happens during the embryo development. So with a bit of background covered now, I'm going to now move on to talk about the reproductive anatomy. So this is where some of the images might start to get a little bit more graphic, but I'd like to believe that given that you have chosen to come here today, you've chosen to learn about these structures. But if at any point you're finding it too much, feel free to obviously just avert your eyes and you can just listen to what we're talking about. So the female reproductive system is made up of external and internal organs. So if we start on the external organs, first of all, then we are looking at this individual from underneath. You can see the edge of their leg here and here, and we are looking up where we can see the anus right here, and we can see these external female organs right here. If we start towards the front, that's where you would expect to see the clitoris. Followed by this open area here known as the vestibule or the vulva. Within there, we can see that we have the labia majora, the sort of outer lips here, which tend to be a bit bigger, and the labia minora towards the inside. You can see them labelled up just here and here. And then in the inside here, you can see the opening to the vagina that will lead up to the uterus. Sitting more towards the front or anteriorly, as we would name it in anatomy, you can see the opening to the urethra. And as I said, sitting more posteriorly or to the back, you can see the opening to the anus. Now around this area, there's lots of glands, for example, the pubic hair and organs and tissues and structures to protect and support this area. If we then move inside, if we imagine we've moved inside this vaginal opening here, then we move up through the vaginal wall to the neck of the uterus, also known as the cervix. So this is the structure that you would expect to expand and open up in order to allow the birthing of the baby during pregnancy. And that baby would travel down through the vagina, known as the birth canal. If we continue inside from the neck of the uterus, known as the cervix, and we reach the uterus, and Arania is going to talk more about the structure of the uterus when she takes over. The uterus connects up to the uterine tube. So we have one uterus, one cervix, one vagina, but we have two uterine tubes, each one leading off to the ovary. And it's within the ovary that you would see the development each month of the follicles or eggs ready to be ovulated. And again, we'll talk through all of these structures in just a moment. So if we now look internally, so this is from a person who has donated their body for anatomical and medical science. And so this individual has been dissected and you can actually see their internal structures. So we are looking here, this is the anterior or their tummy. This is the posterior looking at their bottom here. You can see the rectum here leading down to the anus, so that would connect up to the digestive system. You can see sitting more superiorly or to the above the small intestine, so the guts of the individual. And if we go towards the front, you can see the pubic bone, the pelvic bone here, and you can see the bladder sitting just above that, the urinary bladder. If we then start to think about our reproductive system, we can see the labia majora here. Can't see the other structures so well in this plane of section, but what you can see is this would be the vaginal orifice leading up to the vagina, up to the cervix right here, the neck of the womb, and then leading up to the cervix here. And, oh, sorry, I've got my orientation wrong. Let me start that again. What we have here is the vagina carrying on up here, leading up to the cervix or the neck of the uterus right here. And then this is the bulk of the uterus right here. So the uterus is what some people colloquially might term the womb. And this is the structure where you're going to see any developing embryos or babies growing for an individual who becomes pregnant. And you can see that close proximity of the uterus to the bladder. You can see how as this expands during pregnancy, this is very much going to, actually I've just realised you probably can't see my pointer. Let me put that on. Hopefully you can see that now. What you can see here is this is the uterus right here. This is the cervix or the neck of the uterus, and this right here is the vagina or the birth canal leading down to the external structures here with the labia majora here. We've got the rectum here, bladder here, small intestine here. So you can see as that uterus expands during pregnancy, for example, you can see how that starts to encroach in the abdomen area, starts to press on the intestines, for example, but you can see how it also will press on the bladder and result in the urinary challenges that an individual often faces during pregnancy. And just up here, you can see, if I remove that arrow for 1 second so you can see it more clearly, you can see the uterine tube right here leading off to the ovary over here to the side. So if we now look at the inside, so in this case, we are looking through the abdomen, so through the tummy wall on the anterior, and we're looking down onto the top of these structures. So we can see the urinary bladder here, and we can see the top of the uterus. So we're looking onto the surface abdomen of the individual. You can see the top of the uterus here, and you can nicely see this uterine tube going off to one side and this one going off to the other side. And coloured in, it's obviously not bright red, but coloured in here so that you can see it nicely, you can see the ovary here. And you can see these finger-like projections of the uterine tube that we will talk about later on this evening. So let's move now to think about the ovaries. So we are now looking from the front. We can see the edge of the uterus here. We can see the uterine tubes. These used to be known as the fallopian tubes. However, that was named after a person. And within anatomy, we are trying to move away from using what we call as acronyms, whereby it's naming something after a person. Because we are trying to get better understanding that naming things after a person, that individual may have been the first person often in Western cultures to have identified a structure and therefore named it after themselves. But often what it doesn't do is it doesn't acknowledge perhaps the others who were working alongside them, who also were part of the discovery. And it also doesn't acknowledge our global community, whereby people around the world probably had already identified this or around the same time. So we now name it as the structure, the anatomical function, the location, rather than the person. So fallopian tubes is also the uterine tube, leading up to our ovary right here. So the ovary is a paired structure, sits on the left and the right, and they produce the gametes, also known as oocytes or eggs. Now, these eggs are surrounded by cells known as follicles, and those follicles are really important for producing hormones that support the function of the reproductive system. So they are producing the progesterone and estrogen that you might hear about when it comes to our reproductive systems. The ovaries are quite small and flattened oval shape, around 3 centimetres long, and they're suspended in our upper pelvis or lower abdomen region. Now, what I mean by suspended is, they have some soft tissue, like ligaments, attaching them onto the uterus and to the body wall and onto the uterine tube so that they all stay close together, but they're not rigid. And that's really important because the uterus has to be able to expand in any pregnancy, for example. And in doing so, many of the organs of the abdomen and pelvic region have to kind of move around and make space. And so if the ovary was in a really rigid position, that would make that really difficult. So instead, they're suspended quite loosely by ligaments rather than being directly attached to anything bony, for example. If we then look inside, these things are coming up in order, so I'll bring them up quickly. If we look inside the ovary, what we call that is the histology. So this is what it would look like if we took someone's ovary, we took a slice of that ovary and we looked at it under a microscope. This is just a diagram. It's not what it really looks like, but it is a diagram of what it would look like, whereby around the outside we see lots of tiny immature eggs sitting there ready, waiting each cycle to see if they are recruited to go through differentiation and development. Now, what that means is each month, some of these eggs are recruited. We don't know why, we don't know how many, we don't know which ones get chosen each cycle. All of those remain somewhat unknown to us. But what we do know is that each menstrual cycle, some of these immature eggs will be told start to develop. And they start to get bigger, they start to get more cells, these follicles growing around them, and they start to become more mature and ready to be ovulated or released out of the ovary. As they are maturing, these cells around them, these follicles, are the cells that will produce estrogen and progesterone that are then responsible for the changes in the menstrual cycle. Now, typically, most individuals' menstrual cycles will be around 1 month in length. And at that point, normally, oocyte would be released from the ovary. Now, each menstrual cycle, one ovary will tend to be the what we call the dominant ovary, which means in that cycle, it will be that ovary that will be going through this egg development. It doesn't typically happen in both ovaries within the same month, within the same cycle. It typically happens in one or the other. And once that egg is fully developed, as you can see here, it would then be released out of the ovary to travel through the uterine tube for potential fertilization. The other eggs that started to develop that month but didn't become the dominant one, didn't become the most developed one, those will just die off. And the one that is ovulated or released from the ovary will leave behind these cells, these supporting cells, that is called the corpus luteum. You don't need to worry about the names, but that structure is something that will continue to produce progesterone hormone. And that becomes really, really important if that individual is pregnant that cycle, because this has to produce lots of progesterone in order to keep the lining of the uterus there and nice and thick and ready for that embryo to develop into. And if this isn't producing enough progesterone, then the levels of progesterone fall, the menstrual cycle begins, and that individual who may have been who have conceived and the egg's gone through fertilization, actually that egg wouldn't be able to stick in the uterus, and it would be lost very early in pregnancy, often before the person even maybe knows they were pregnant. So a female, when she forms as an embryo in utero, actually forms all the eggs she's ever going to have. So my little girl who popped in here a few minutes ago, while she was an embryo growing inside my uterus, she already had formed all of the eggs she's ever going to form. So another way to put it is that any future grandchild that I have actually formed as an egg inside me before I gave birth to my daughter. Which I think is both nice and a little bit weird when you think about it. But while that female is an embryo in the uterus, they will form around 5 million eggs. Now, from birth until puberty, around 3 million of those eggs will break down, and we don't know why. This is quite likely some sort of sense checking process, getting rid of the eggs that are actually not that healthy, knowing that the body needs the best eggs to remain in order to be the ones that are going to produce a child later on, if that individual wants to have children. So by birth, an individual would be left with around 2 million eggs, but only around 400 of those eggs will complete development and be ovulated in a typical female if we go from puberty to menstruation. So lots of those will never ever be used. There's a lot of redundancy in this situation. Lots of eggs will mature each cycle, but only one of them will be ovulated each cycle, as I said. And the human egg, the oocyte, is actually one of the largest cells in the human body. It's almost big enough to be visible by the naked eye. And it actually typically measures just under 0.1 of a millimetre. So it's still really tiny, but just about visible with the naked eye. So as I mentioned, each cycle, some of these eggs with their surrounding supporting follicles will be stimulated to go through this development process, but usually only one would be ovulated that cycle. However, I say usually because some individuals might ovulate more than one, and that's what happens in the case of non-identical twins. In non-identical twins, there has been 2 oocytes or eggs ovulated that cycle. Both of them happen to be fertilized by 2 separate sperm. And so really what those individuals are siblings that happen to be conceived within the same pregnancy. Very different from identical twins, whereby that's come from one egg and one sperm that has been fertilized, and then when it started to divide to form the early embryo, it's then split in 2, creating this identical copy embryo, which is how they become identical twins. So all the other eggs that are not ovulated, but had started to go through development, those will just degenerate in that cycle. And as I mentioned, the corpus luteum is left behind, and it becomes bigger and secretes hormones like progesterone and estrogen. Now, after around 10 days, this corpus luteum will degenerate, and in doing so, that causes a very quick decline in the levels of progesterone, which causes the menstrual cycle and that bleeding, which Arania will talk to you about in a few minutes. But if that individual does, the egg becomes fertilized, they conceive and pregnancy continues, that corpus luteum will continue to enlarge and remain throughout pregnancy, giving lots of progesterone in order to maintain that uterine lining to support that developing baby. So before we move on to the rest of the reproductive system, I just wanted to quickly touch on polycystic ovarian syndrome. So this is something that has been gathering a little bit more attention over the last few decades, both in terms of research and hopefully medical practice. So PCOS is something that affects the ovaries and as a result, the endocrine system. Now, ovaries in individuals with PCOS often have multiple small cysts within them. Now, those small cysts tend to be the follicles that started to grow and develop in a cycle but failed to ovulate. In most individuals, those follicles will just degenerate and just disappear, ready for the next cycle to begin. But individuals with PCOS, it's thought that these follicles aren't actually completely degenerating and leaving behind instead multiple small cysts. Now, in doing so, we mentioned that the cells that are left behind after the egg is ovulated, those follicular cells are really important for producing hormones. So as you can imagine, if these individuals are having lots of these follicle cells left behind after ovulation, it means that they are continuing to produce hormones that are maybe not required at that time. So these individuals often result in a hormonal imbalance where they have an increase in the hormones androgens. Now, some people think of these as the male hormones, but actually females have androgens too. There's nothing male about these hormones. Everyone has androgens, and in individuals with PCOS, they tend to have too much of these hormones, which is what can result in the acne that we see in individuals with PCOS and, for example, excess hair growth. We also see increased levels of luteinizing hormone and follicle stimulating hormone. Now, you don't need to worry too much about the names of those hormones, but those hormones are what drives the eggs and the follicles to go through development in each cycle. And so having too much LH and not enough FSH in that cycle can result in the irregular ovulation that individuals with PCOS sometimes see. And these individuals also tend to have an increase in insulin resistance, which means they're at higher risk of weight gain and diabetes. So it's thought that PCOS affects maybe around 10% of women of reproductive age globally, with around 70% of the cases actually being undiagnosed. It can be quite tricky to get a diagnosis of PCOS. The majority of individuals with PCOS will also have insulin resistance, which means it's treating not just a reproductive challenge, but also something that might have other knock-on health impacts. And the common symptoms would be irregular periods, excess hair growth, acne, and infertility is often a reason individuals present to a GP for investigation, and that is when often the diagnosis comes. So on that note, I will stop sharing my slides and I will allow Arania to take over, and we will hang around and be here at the end to handle any questions.
Fantastic. Thank you so much, Michelle. So I'm just about to share my screen, so please bear with me. So I hope you can see my screen okay, my laser pointer as well. So I'll follow up from where Michelle left off. So I will discuss the uterine tubes. So here we can see the anatomy, and what I'll do is I'll bring all the text up to make life easier, and I will cover this one by one. So when we're thinking about the uterine tubes, we have one to the right and one to the left. They're paired structures, and they're roughly 10 centimeters long. And we can see here one of them right here. They extend between the ovary and the uterus. By the way, I'm really sorry for the background noise. That's my child shouting in the background, so apologies if you can hear that. So they extend between the ovary, which we see here, and they provide that connection to the uterus. However, I have to make a wee note here that they don't directly connect to the ovary, but what happens, they're in very close proximity to the ovary. So when the oocyte is released from the ovary, these little fimbria, which are like hair-like structures, they grab that oocyte and they pull it into the tube. And this is also a wee opening that exists between the female reproductive system and the rest of the peritoneal cavity, which refers basically to our tummy. And the uterine tubes are very important because they allow for that egg, for that oocyte to be moved slowly between the site of production, which is the ovary, into the uterus. And it's actually where the fertilization takes place. It's where the sperm will meet at the oocyte and where the embryo will first form, and slowly as the embryo is developing, it will travel towards the uterus, where implantation, where basically the embryo will go and latch and start developing. And the fertilized egg travels for approximately 6 to 10 days until it reaches the uterus, and uterus is ultimately where we would like that pregnancy to continue. Sometimes things can go wrong, however, and we may end up with what is called an ectopic pregnancy. Ectopic is basically a fancy word for saying that is not where it should be, which is the uterus. And this is where the fertilized egg implants outside, and this can include the uterine tube. It may include the ovary. It may also include the abdominal space, so that's our tummy, or it can be further down towards the neck of the uterus, which is the cervix. This happens roughly in 1 in 100 pregnancies, so it's not as common, but it can be life-threatening. Because of course the embryo does not have the ability to grow in the uterus like they do in the uterus. There is a couple of risk factors that can predispose us to ectopic pregnancies that may involve smoking, has been shown as a risk factor, and pelvic inflammatory disease. And as Michelle was very nicely discussing earlier, the uterine tubes is the name that we prefer to use nowadays. Initially were termed fallopian tubes, and that's because they were named after Gabriele Fallopio, who was a 16th century Italian anatomist. So very much at that stage, when different anatomical structures or different medical discoveries were made, they were named after the person who made those. But that name does not reflect the description of or the function of that particular structure. The description is that the tubes carry the eggs from the ovaries to the uterus, and they're critical in the process of fertilization. That's why we are reverting nowadays, as Michelle was saying, to the descriptive name, because it accurately reflects what the structure does, and also it removes any potential bias, but also any potential misunderstandings that may be created. And this doesn't just focus specifically into the uterine tubes. This is a wider thing about eponyms. They lack that descriptive clarity. So what does that anatomical structure do? Why do we need to have that description? The fallopian tube in this case does not describe the structure's function or its location. Uterine tubes instead is much more clear, describes the role in connecting the ovaries to the uterus, makes it a lot easier for everyone to understand what we're talking about, especially when we're passing this information to the general public. There is also a historical legacy and gender bias, which would be perpetuated by using these eponyms. Many structures, including, for example, the uterine tubes, are named mostly after white male individuals who discovered them. And that again was because they were able to study at that particular era and make these discoveries. This prevents us from giving recognition to their function, but also shifting to more functional terms helps us remove the bias and promote a more inclusive and descriptive understanding of human anatomy. And something which is quite important, especially for training the new generation of healthcare professionals and scientists, is that eponyms can be confusing. They can cause confusion because they can vary depending on the country, on the culture, and the medical practice. This is a very Italian name, for example. It doesn't associate with a specific description, but also it doesn't help a person who is learning about human anatomy to easily remember that particular name. On the other hand, the use of descriptive anatomical names helps avoid any of that ambiguity, especially for students and healthcare professionals, especially when we're working in an increasingly international and globalized context. Again, what I'm going to do here, I'm just going to bring all of this to make life easier. So now that we have discussed the ovaries and the uterine tubes, the next one is the uterus, which is commonly known as the womb. The uterus is pear-shaped, and I'm specifically referring to the uterus that is not carrying an embryo and is roughly 7.5 centimeters long. And we can see it here. This is again specific sections from a donor who very kindly donated their body for anatomical examination and a scientific study. And here what we see is the uterus from the side. So it's if we're looking from the right or the left side. And we notice that different parts of the uterus have been colored to show the different parts of them. So we have the top part, which is known as the fundus. We have the body, and we have the neck, which is the cervix. And as we notice here, the uterus is a hollow muscular organ, and it's the site of embryo implantation, and it has a direct connection with the vagina. And as we did before with the ovaries, another important condition that links with the uterus is endometriosis. So endometriosis occurs when tissue similar to the uterine lining, which is known as endometrium, grows outside of the uterus, and this shouldn't happen. Common sites can include, for example, the ovaries, and they can even sometimes develop, into little cysts known as chocolate cysts. We can have fallopian tubes, the pelvic lining, and in severe cases, even the bladder on the intestines. And remember, this happens in the intestines because we have that connection between, that open connection between the uterine tube and the rest of our tummy. And what happens because this tissue is coded to think like the uterine lining, it thickens and breaks down and bleeds while we're having our menstrual cycle. But because it doesn't have a direct opening with the vagina, there is no way for that shedding to exceed. So it can't go anywhere. So it tends to get trapped wherever it is. If it's in small amounts, for example, it can be reabsorbed, but if it's chronic and persistent, it can lead to chronic pain and inflammation, which can be quite debilitating. It can also lead, if it continues, to scar tissue and adhesions. And adhesions is when different organs tend to stick together. And organs are not supposed to do that. They're supposed to be flexible. They adhere to different parts, but they are flexible so that when we breathe in and out, for example, they can move around as well. But with that scar tissue that is prevented, what we also have, as I mentioned before, we can have endometriomas in the ovaries, which are the cysts. And if these cysts bleed, they can be extremely painful. And in some cases, we can even have a contribution to infertility. So what are the key statistics when we're thinking about endometriosis? It affects roughly 10% of our population, when we're thinking about women and those assigned female at birth. The average diagnosis, actually, there is a little bit of a delay, and there is a lot of different reasons which we can discuss at the end of this talk, but they tend to be 7 to 10 years. Roughly 50 to 60% of individuals with painful periods may have endometriosis or at the beginning of endometriosis, and up to 50% of women with infertility have endometriosis. And there is also high risk of autoimmune conditions and chronic fatigue for a variety of different reasons. What we need to appreciate here is that endometriosis has no cure, and treatments are supported in terms of managing pain, hormonal therapy, and surgery. And there needs to be here a lot of training when it comes to healthcare professionals to understand and identify these symptoms early, so that, of course, we can close that diagnosis gap and help individuals who are suffering from endometriosis as soon as possible, so that we don't lead to this scar tissue and adhesion situation. Again, I'm going to bring all this information. There we go. So the next part, which we mentioned again, is the uterus. But what I would like to touch on here is the way it is positioned. So, and I'm sorry, I'm moving different things so I can see my screen. So what do we have here? First of all, understanding the anatomy. So where is the uterus? Here again is looking at this anatomical illustration, And it's as if we're looking from the right side or the left side of an individual. And what we notice, this is the front part, and this is the back part where the bottom is. And if we're to move in relation to the uterus, we notice the bladder just in front of the uterus. And just posterior to the uterus and the vagina, we notice the rectum and the close proximity between these structures. The uterus tends to lean forward just above just above the bladder. Night. I'm sorry. Bye. Good night. Oh my God. My husband just destroyed my boy. I'm sorry. I'm so sorry about this. So it tends to lean anterior to the uterus. Sometimes in 25% of the cases, it can also be retroflexed, which is absolutely normal. It can cause a little bit of pain, but it doesn't cause any influence on fertility. And sometimes it tends to flip forward after pregnancy. What is important to notice here is that the pelvic floor muscles support and hold these structures in place. And it's very important to keep that in mind, especially after pregnancy, and also how we can maintain the pelvic floor. If for any reason, if these muscles weaken, let's say after trauma or after a pregnancy, then different structures, including, for example, the uterus, in some severe cases, the vagina as well, they may end up as prolapse, which means the structures, they don't have a support network and they can come forward outwards. The next part, again, is the cervix. I'll bring all the information, so please bear with me, and I'll move some things around. So as we said before, the cervix is the neck of the uterus, is the most inferior part of the uterus, which we notice here, and is that direct connection with the vagina. And it's that part of the female reproductive system that is open to the outside world. So because of that, it is vulnerable to pathogens and bacteria, but it has a very smart protective mechanism, and that is the cervical mucus glands. And these glands provide that physical barrier to any outside substances that may be seen as harmful, both to the vagina, but also specifically to the uterus. Sometimes that barrier also can be too good, so it can prevent the sperm from entering where it should be, which is the uterus, so it can travel to the uterine tubes and continue with fertilization. So what happens to prevent that? Again, near ovulation, that consistency of the mucus changes and becomes thinner to allow for the sperm to travel upwards. And we can very nicely see here the different cells of the cervix. I'm not going to go into any detail of that, but just out of interest, we have included them here. The next part is the vagina, which is the continuation. Again, I'll bring all the information. Oops, too fast. Again, this is a muscular tube. It's roughly 10 centimeters, but again, that can vary depending on which stage we are in our growth. Also, whether there has been any pregnancies or not, or any surgical procedures. And it extends between the neck of the uterus, which is the cervix, all the way to the vulva. It's again, as I said, a muscular tube, and the inner layer of the wall creates mucus, lubrication, secretions, which are important, especially during intercourse, to allow for intercourse that is not painful, of course. The muscular layer allows the vagina to enlarge during intercourse, but also during childbirth. And the outer membrane anchors the vagina so that it can stay in place in relation to the rest of the organs that we discussed. Most anteriorly, we can have the hymen, which is the mucous membrane covering the vaginal orifice, but of course that can be quite variable as well. So that's the gateway to the uterus. So it has to make sure that it protects the uterus. So the acidity of the vagina can be different compared to other parts of the human body, and that is as a protective mechanism. It is also the passageway for the menstrual flow. When the uterus sheds, the blood comes out and through the vagina, through the vulva into the outer world. And again, of course, the birth canal during labor. And here what we have is a very nice image of a person who had probably an investigation, and we can see the real, instead of anatomical illustration, the real uterus as it sits just above the bladder. This is an anteroverted uterus. We can also see here the cervix and the vagina as well. And just posterior, just on the back part, we can notice the rectum and the intestines here as well. And something that is quite important is actually distinguishing the vagina from the vulva. So the vagina is very much an internal structure and is that passageway, whereas the vulva is what we see on the external aspects, so on the outside. So the vestibule is the space which contains different openings, including the urethral opening, which is where urine passes through, the vaginal opening, and we can see here the urethra there, and the vaginal opening here as well. And most posterior also, we have the anus, so as we go towards our bottom. The vestibule also contains different mucus glands. It also has the different folds. These are known as the labia minora. And it also has the erectile tissue for females, which is known as the clitoris. If we are to move further out on either side, we notice the labia majora, which is again rounded folds of skin towards the outer surfaces. And again, these contain different structures, including sebaceous and sweat glands, and together they come and they form the mons pubis in the front aspect, which can be a little bit elevated as well, and that is normal anatomy. There's quite a lot of variation which falls within normal anatomy, and that comes with how the structures are developed during embryology. Now I'll move us into the function of the reproductive system, and specifically I will move us into the different hormones and how the different hormones of the human body work together. So the female body and the human body in general, actually, I should say rather, it has a very smart connection between the brain and the different parts of the endocrine system. So from the pituitary gland in the brain, we have different hormones that are secreted. And this is a small structure that is nicely buried in the deep part, in the center of the brain. It produces, in this particular case, hormones that are important, including the follicle-stimulating hormone and the luteinizing hormone. These travel through the bloodstream into the different parts of the human body, and specifically, they travel into the ovaries. And they stimulate the production of hormones which are important, such as estrogen and progesterone. And these are the hormones that then regulate the ovarian activity. So what we see here, for example, is when different pituitary hormones increase, how they can stimulate the estrogen and progesterone. So first we notice that increase in our menstrual cycle, and we have the days here of that peak of estrogen. That is accompanied with what we see here of, this is the development of the oocyte. We can see how it's developing and how that links very nicely with the peak of estrogen, with a release here of that oocyte, which is very close to ovulation. And then when that happens, that estrogen is not required at this stage, so it starts dropping, but instead we need to have that uterine lining being prepared, so other hormones start taking over. If there is fertilization, that process will stop, but if there isn't fertilization, what happens is that progesterone peaks, and then we have the secretory phase of the uterine lining. So the uterus becomes very thick, there is no implantation, and it starts setting, which is the premenstrual phase before the period starts. And that again starts again on a cyclical phase. So it's a very nice, what's the best way? It's like a well-oiled machine. Everything happens in a specific time. If all of these hormones doesn't do what it should do at a specific time, of course it can lead to an issue. So it's everything timed. And this fits very nicely with menopause. So menopause is the natural biological process of marking the end of menstruation. Typically starts between the ages of 45 to 55, but again, there can be variability there. The ovarian function declines, leading to lower estrogen and progesterone levels. And these changes can affect not just the reproductive system, but the whole human body. And I think that's some of the misconceptions that we are trying to tackle with. So in terms of the reproductive system, the ovaries stop releasing the oocytes and the menstrual cycle ends, or it can become more sporadic at the start of the menopause. But also the endocrine system, which is a system that controls the different hormones, because the estrogen, we have the estrogen drop, that can affect the metabolism and of course the distribution of fat on the human body. Again, because we have the drop of estrogen, there can be that protective effect from estrogen that females have, or actually, I'm not going to go in that conversation, but people who take estrogen as well. That protective effect from the cardiovascular system is removed, so there is an increased risk of heart disease. In terms of the skeletal system, the bone density changes, and that's why people who are going through menopause, they're at high risk of osteoporosis. And also it affects the nervous systems. It changes the way, again, because the hormones change, it affects the way the vessels dilate and vasodilate. So individuals may experience hot flashes, mood changes, but also sleep disturbances. Roughly 1.2 million women worldwide will be menopausal by 2030, so it's quite a significant part of the population. So it's important to be able to understand these symptoms and the physiology of why they happen and how to support them. 80% experience symptoms like hot flashes, night sweats, and mood swings, which can be debilitating, and 1 in 3 women after 50 will experience osteoporosis-related fractures. So it's quite important to appreciate that link with osteoporosis and see how we can provide supportive care. There is also the higher risk of heart disease with a 10-year postmenopausal heart attack risk increase as well. So this is the end of the talk. And again, I'm sorry about the interruption. I hope it has been useful. I will leave this QR code here. But what I can actually do to make life easier so that we can see each other is I can stop sharing and I can put the link on the chat.